Good afternoon and welcome to the first in a new series of satellite seminars which focus on the implementation of National Institute for Clinical Excellence NICE guidelines. Plymouth Primary Care Trust, Plymouth Hospitals Trust and the Institute of Health Studies have collaborated to form a Plymouth Health Community NICE guidelines implementation group. The group aims to offer bi-monthly workshops and a satellite seminar on selected NICE guidelines. Today is the first of these satellite seminars and is entitled NICE Guidance Implementation for Orlistat, Sibutramine and Surgery for Morbid Obesity. To commence, Dr. Morag Prowse, Head of the Department of Clinical Studies in Adult Nursing, offers an overview and critique of the evidence for the 3 NICE guidelines relating to treatment for obesity. Then Professor Terence Wilkin, an expert in this field, provides an overview of the impact of obesity on the health of the population, locally and nationally, and in addition reviews current practice in the medical management of obesity. Our panel will then discuss factors which influence the implementation of this NICE guidance in the local health community. As usual, you're invited to participate in our seminar through studio discussion. You may either telephone or email us with your questions and comments. The telephone number is on your screen there, 01752 233 646. And the email address is tvstudio@plymouth.ac.uk. We will be ready to receive your calls at approximately 25 to 1. Today's panel consists of Dr. Rosie Heath, a local GP, Professor Terence Wilkin, a specialist in endocrinology and obesity management, Dr. Gillian Vivian, consultant in nuclear medicine, who chaired this week's workshop, and Christina O'Riordan, a senior dietitian from Plymouth Hospitals Trust. Welcome to you all, and thank you for your participation. Now, without further ado, I hand over to Morag.
Good afternoon, and can I echo Val's welcome to the first of the NICE Guidance Implementation Seminars. My role today is to briefly review the technology appraisals for 3 drugs, the 2 drugs, Orlistat and Sibutramine, and the surgery for morbid obesity. But my particular focus is to consider the evidence underpinning this particular NICE guidance and make some judgments about the quality of that evidence. In evidence-based healthcare and evidence-based medicine, the effectiveness of interventions such as drugs or surgery is judged against an established hierarchy of levels of evidence, and it would be useful before we start reviewing the technology appraisals just to recap these levels of evidence. This is derived from the well-established work by Sackett and colleagues from the Canadian Task Force in '96. These levels of evidence form a hierarchy. At the pinnacle of the hierarchy is experimental methods, but in particular randomized control trials and systematic reviews and meta-analysis of these randomized controlled trials. This is usually assigned a number 1. In the levels of evidence, 1 can be a 1+ or a 1- depending on the quality of the studies involved. But the key point for us to note is something that's given a 1 level of evidence is gold standard and has statistical power when we talk about the effectiveness of interventions, which is really what we're discussing today. As we come down the hierarchy, we have systematic reviews of case control and cohort studies where we have less statistical power, but we can still be reasonably confident about the effectiveness of the intervention. Non-analytic studies, which include qualitative research studies which tell us about the patient's perspective another very important aspect of interventions. And at the bottom of this particular hierarchy is expert opinion. But in some cases, the best available evidence is expert opinion. As well as this hierarchy of levels of evidence, with systematic reviews given a 1 and expert opinion given a 5, evidence is graded in terms of A, B, C and D. A level evidence or grade of evidence again is considered high quality. So as I go through the technology appraisals today, if I assign something a level 1 plus or minus and a grade A, it would be taken to be high quality evidence. The first drug that I'd like to consider is a drug called Orlistat. The technology guidance was issued in March 2001, and with all of the technology appraisals, this will be reviewed 3 years later. The pattern for reviewing the technology appraisals will be looking at the mode of action, how the drug works, and what side effects the patients might experience. This particular drug works by very effectively reducing fat absorption from the gastrointestinal tract. Because of the way it works, patients might experience a reduced absorption of fat-soluble vitamins, which can create dietary problems. But the patients can experience a range of quite distressing gastrointestinal side effects related to increased bowel movement, frequency of bowel movement, and anal leakage or anal soiling. An important point to note here is that if the patients are in the experimental part of the research, they're likely to be aware that they're having gastrointestinal side effects, as are the researchers who are carrying out the study. Orlistat's indicated for use with a BMI or body mass index of 28 with comorbidities. And in terms of body mass index, someone of my height, 5'4", if my BMI was 30, I would actually weigh 80 kilograms, or for those of us like me that haven't quite converted to metric, I would be about 13 stone. The drug is indicated for use only between patients between the ages of 18 and 75. And for this particular drug, the recommendation is the patient should have demonstrated motivation by a weight loss of 2.5 kilogram in the months before treatment commences. And this is a very key aspect because managing weight is a long-term problem. And it could be argued drugs provide short-term solutions. Use is indicated when there is concurrent advice, support. This can include diet, behavioural change, increase in physical activity. Patients continue on the drug if they've lost 5% of body weight after 3 months, and if they go on to lose a further 10% after 6 months. But the drug is not indicated for use beyond a year. When we consider now the effectiveness, patients do lose weight on these drugs, and they lose weight at a faster rate than patients in the control group over a year. They have a reduction in comorbidities. And not surprisingly, the patients tend to feel better. They have an increased patient well-being because they have, in fact, managed to lose weight. In general, patients do regain weight after drug therapy or after dietary changes. But looking at the trials, the weight was regained at a slower rate than the rate it was lost during therapy. When we come now to look at the quality of the evidence, the evidence is based on systematic review of 14 RCTs, randomized controlled trials, with some risk of bias, but the risk of bias is almost inevitable in studies carried out outside of laboratory settings. On that basis, I think this evidence would be rated as a 1+ and a grade A, because the quality of the RCTs was generally high. Some issues and gaps in the evidence are worth considering. And in terms of judging quality of evidence, there are 2 things that researchers tend to look at. Is the study internally valid? Has it high internal validity? And does it have external validity? Things that can affect internal validity come in 2 categories. They can be either biases, which tend to be things to do with aspects of method, or they can be confounders, something that could influence the treatment effect. And those are important aspects to consider as we make judgments about the quality of evidence. External validity of a study refers to the ability to generalize from the particular study to a wider population. In general terms, where randomization has taken place, the external validity of the study can be reasonably assured. For this particular technology appraisal, there were issues really here because there wasn't a stratification for very important variables, and you can see them outlined here: gender, ethnicity, social class, social group, and a family history of obesity. And the studies don't give us any evidence of how this particular set of data was included. There were issues about the validity of blinding. This is one of these biases I've just mentioned. For a really good experimental approach in a randomized controlled trial, ideally, neither the person taking part in the study nor the researchers know who's in the active treatment group. Now, clearly, if you're taking a drug like Orlistat and you have distressing gastrointestinal side effects, you are likely to be aware, and reporting them to the researchers monitoring the variables is likely to alert them. This is likely to happen in a number of studies of this kind, but there were validity issues to do with blinding. The next technology appraisal reviews a second drug, and this drug is Sibutramine, and this appraisal was issued 6 months after Orlistat. And interesting to note that two drugs working in similar ways, though different modes of action, where the appraisals were done 6 months apart. The way this particular drug works is by affecting central neurotransmitters. In effect, what it does is it creates a situation where the patient has a reduced appetite and therefore takes in less and loses weight. In terms of side effects, they're likely to be an increase in blood pressure and changes in pulse rate. And with these particular side effects, the patient might be less aware that they had an elevated blood pressure. Use is indicated with a BMI of 27 and comorbidities, or a BMI of 30 or greater. The age range this time is between 18 and 65, and similar advice, although the drug manufacturers highlighted at our workshop on Monday that in fact the prescriber's information for this particular drug suggests that as there are people who have grave difficulty losing weight for a number of reasons, that this drug can in fact be prescribed when patients have not lost weight in the month before prescribing. As with Orlistat, there should be concurrent advice support available to the patient. This could be one of the confounders that we have to think about in terms of research evidence, because if different general practices and different health service contexts provide varying concurrent advice and support, patients may well have better advice and support in one area than another. And that might affect the confidence that we can have in the effectiveness of the drug. Patients on Sibutramine, again, the guidance this time really says not to continue the drug therapy beyond 1 year. In terms of its effectiveness, as with Orlistat, patients do lose weight. Some of the risk factors associated with obesity showed changes, and some of these are highlighted here: cholesterol levels, triglyceride, waist circumference, and waist-hip ratio. If we're making a judgment about the quality of this particular evidence, again it's a systematic review, this time of 16 RCTs with some risk of bias. So it would be a 1+ and a grade A evidence. In general, the quality of the RCTs was high. Issues and gaps in the evidence, very similar as for Orlistat. But because this drug has been issued 6 months, the guidance has been issued 6 months after Orlistat, there's clearly a need for comparative studies to look at combinations of these two drugs and behavioural therapy. Validity of blinding was again an issue in terms of the internal validity of the study. And some other issues picked up with these studies. There was a failure to use something called intention to treat analysis, and this is really a way of pulling the data, and in method terms, failing to use that can reduce the internal validity. There's a possibility of bias in non-random withdrawal of subjects. And the reduction in the risk factors were not all statistically significant. And this goes back to statistical power and the hierarchy and levels of evidence. With these particular RCTs, there was use of a method of last observation carried forward. And what this means is that as the patients withdrew from the study, the last observation of the variable, in this case weight, would be taken forward in the next rounds of analysis, as if the patient had stayed in the study. And this can over or underestimate treatment effects and reduce the internal validity of the study. Some other issues were variable reporting of patients that were withdrawing from the study. And going back to external validity, if we consider how generalizable the findings are, clearly we have a large a group of people under 18 and over 65 who have problems with weight management. But what we can't say from the technology appraisal is that we can generalize to these age ranges. The last technology appraisal I'd like to very briefly review is the surgery for morbid obesity. This was issued by NICE in July of this year, so it's a very new appraisal. In terms of mode of action, the surgery works by either creating a malabsorption situation or restriction or a combination of the two, which will reduce weight. The side effects in this particular intervention very much relate to the type of intervention, the operative procedure, and very significantly the post-operative complications, which include complications related to surgery and to anaesthesia. The use of surgery for morbid obesity, here we're looking at a BMI in excess of 40. This is morbid obesity. Or a BMI 35 to 40 with comorbidities. Patients must be over 18 to give consent to this surgery and to give fully informed consent. With this group of patients, they must be managed by hospital obesity clinics. There must be an absence of clinical or psychological contraindications. They must be fit for surgery and anaesthesia, although a patient with a BMI of 40 is likely to be an ASA grade 2 or 3, which means that they have some risk of anaesthesia because of the obesity. And very significantly, the patient must accept and understand the need for follow-up. In terms of the effectiveness of the procedure, the evidence is very complex, and unlike the technology appraisals for Orlistat and Sibutramine, where there was a synthesis of similar RCTs, the evidence for the surgery for morbid obesity is done in a rather patchwork way that makes a synthesis really quite difficult. For example, 2 RCTs compared surgery with conventional treatment, 15 RCTs compared up to 6 different surgical procedures, and the RCTs were all of varying methodological quality. So I hope that you can see that it's quite difficult to make a judgment about the quality of evidence because of the complex nature of the evidence. In terms of surgery versus conventional treatment, there were 2 RCTs and 1 clinical trial. One of the RCTs was high quality and it would be assigned a 1+, but one RCT had some serious deficits in method which would reduce the internal validity and the external validity, and so that would be assigned probably a 1- and possibly even a 2. The effectiveness of surgical procedures. It's been difficult to summarise, but I shall try to do that. One of the procedures, jejunal-ileal bypass, was extremely effective in weight loss, but had such serious complications that its use is not recommended, but it was included in the trials. Gastric bypass, in general, was more effective than gastroplasty, but was technically more difficult and had more serious complications. Vertical banding, another procedure, was shown to be more effective than horizontal gastroplasty. And in general, surgery carried out via the laparoscopic method was as effective as open surgery, but carried less complications for the patients. And I'll now pass you back to Val in the studio.
Okay, well, thanks very much indeed, Morag. I've followed that very closely indeed. It was a most interesting presentation, and some most interesting results to date. I'd now like to take the opportunity to hand over to Professor Terence Wilkin, who's going to provide an overview of the impact of some of the things that have been referred to now. Over to you.
Thank you very much, Val. I want to start by giving some idea of the size of this problem, and then I want to try and break it down a little bit and try and convey why it's so important to health and not just to appearance. In the modern day, I think we have seen over the past generation an increase in the frequency of obesity, something like threefold. These figures come over the 20 years between 1980 and 2000, and they really are quite frightening. If we look at the population as a whole, then well over 60% of young adult males and females are now overweight, and some 20% of them are frankly obese. These figures, if we compare them going back 20 or 30 years, would be quite different. This is a modern disorder of some proportion. And the question inevitably arises, well, does it matter? And if it matters, why does it matter? To the patient, of course, it often matters for cosmetic reasons, and those are important. But for health, it matters for quite different reasons, and these are not always fully understood. The real basis for the pathology behind obesity lies with its relationship to insulin. I think all of us as doctors and nurses have always linked insulin to glucose and glucose and insulin to diabetes. But what we've come to realize over the past 10 or 15 years or so is that insulin has a much broader action in the body than simply controlling blood glucose. And the problem with obesity is, and this is the same for anybody who puts on body weight, they will increase their insulin levels. Ultimately, the blood glucose levels will rise as well, and diabetes, of course, is a well-known complication of obesity. But it's not the complication that really threatens the health of the patient. The real complications come from a lot of other disturbances that are insulin-related. If we look at these then in some detail and try and enumerate and identify them, if your insulin levels begin to rise, you will begin to drive up your blood pressure. You'll begin to drive up your blood fats, the lipids, cholesterol, LDL cholesterol in particular, triglycerides. You begin to drive up the number of blood cells that circulate in your blood. This increases the viscosity of the blood. You increase the levels of coagulation factors produced by the liver. You increase the levels of uric acid produced in the body. Now, each of these in itself is an independent risk factor for coronary heart disease and disease of the large blood vessels. But if you put all these together, and this is where the real problem lies, if you put all these together, then you have a really serious threat to cardiovascular health. And it is this rise in insulin, consequent upon the rise in body mass, that has led over the past 50 years or so, I suppose, since the Second World War really, to this incremental rise in cardiovascular risk amongst young people, particularly sort of middle-aged adults. And until we are rid of this problem, we almost certainly will be left with a much higher than necessary incidence of heart disease, stroke, high blood pressure, kidney disease and so forth, and of course the diabetes that is always associated with obesity. If we look at the diabetes for one moment, the relationship is so strong as to be really frightening. If you look at what's called a referent population, this is a population for comparison, population with a BMI less than 22. There are relatively few people, particularly in adulthood, who can boast a BMI of less than 22. Nevertheless, by the time the BMI has risen to 23, already the risk of diabetes is 3 or 4 times greater. By the time an individual is of a BMI exceeding 25, that is to say by WHO definition overweight, the risk of diabetes has increased now 8-fold. Now we can follow this relationship upwards to the point where if you are reaching the areas of serious obesity, BMI 35 plus, the risk of diabetes is now 90-fold. There is an exponential relationship between these two But I want to take the emphasis of that relationship with the diabetes and replace it with this notion that really the problem that's associated with the diabetes and the obesity is cardiovascular risk. We've always talked of the cardiovascular complications of diabetes, but we should rethink that one and talk about the cardiovascular associations, because they are all associations of insulin resistance, high insulin levels, and those are all associations of obesity. Even then, though, the problem isn't that straightforward, because you simply cannot determine or predict your insulin resistance from your body weight or from your BMI. What matters very much indeed is where you distribute your body weight. And some 50 years ago, a Frenchman by the name of Varg from Marseille first described what people popularly know as the apples and the pears. The apples are those who carry their body weight in their abdomens, and the pears are those who carry it lower down. I think the politically correct term is gluteofemoral, but we're all talking about butts and thighs, really. In broad terms, the abdominal distribution of fat is the male distribution of fat. That's where most males, if they become overweight, will place their fat. And this isn't fat under the skin. This is fat actually within the abdominal cavity, surrounding the abdominal organs. And there it is dangerous, because it causes a rise in blood insulin that drives all those other complications I've been talking about. If the same amount of fat is held elsewhere, in the hips or in the thighs, the BMI may be exactly the same, but this is entirely harmless fat. So that you cannot use BMI on its own very accurately for selecting patients who have a health problem from their obesity rather than merely a weight problem associated with it. And I think that's quite important. Now, there is another factor here that I think is worth mentioning, because we're talking by and large about adults, and I think we need to come down the age scale and see what's happening to children nowadays. We in Plymouth at the university run a fairly large study known as the Early Bird Study, which is observing what is happening in relation to insulin levels and the various metabolic disturbances associated with it in very young children from the time they enter school. And already at the age of 4.9 years, the children of Plymouth, and there's no reason to believe that it's different elsewhere, have an obesity problem. 30% of the girls are already overweight. 10% of the girls aged 4.9 years are already by definition obese. And there is a clear relationship between their insulin levels, their triglyceride levels, their LDL cholesterol levels, and their body weight. But it may go back even further than that, because although we have for some years been concerned that obese children turn into obese adults, not always the case, but frequently it is, we're now concerned that overweight mothers may breed children who are programmed to be overweight. In other words, can't escape the tendency because it's been put into their metabolic processes at a time when their development is still very plastic during gestation. And there is now data emerging to suggest that overweight mothers produce children who have, from the time of birth, a higher insulin level than is good for them, and will carry that through life. And that is really a serious problem to contemplate. And you might be looking in 10 years' time, perhaps even less than 10 years, at the proposal of not only giving the pre-pregnant mother a prescription for her folate, but giving her a dietary prescription at the same time, because it may be as important to the health of her offspring that her folate be replete as it is for her weight to be relatively normal, so that the child is born with the best chances in life. Now, I just want to turn for a final 3 or 4 minutes to the clinical aspects of managing obesity. In Plymouth, we have a research obesity clinic, which Christina, whom we'll be talking to in a moment, runs as a senior dietitian in the hospital at Derriford. And this clinic is devised specifically for those who are young and at risk. It is not designed to treat the obese of Plymouth. There are simply far too many of them. And we select patients between the ages of 18 and 35, and we select patients very specifically who already have a metabolic problem that we know will turn into disease unless we do something about it. And the kind of analogy I would use here is that of a stick of dynamite exploding, because if the day that diabetes is diagnosed or a stroke occurs or a heart attack occurs is represented by an explosion of that dynamite, then a fuse has been burning for years. And I think we have to start thinking about what lights that fuse, what keeps it burning, and how, before the detonation occurs, can we put it out. So we are looking for young people who might have gestational diabetes, a marker for future diabetes and this problem of insulin resistance, who might have a family history of hypertension or premature heart attack, who might themselves be troubled with infertility. Not something I've mentioned so far, but an increasing number of young obese women cannot ovulate because their insulin levels are too high. Now that in itself is a problem, but is also a marker for what's to come if something isn't done to reverse it. In order to select such patients, one obviously needs some kind of strategy. And public health specialists would have a strategy which might be of two kinds. One would be to try and shift the whole of the population down the scale of obesity, which is a major logistic effort, but an important one, and that's the sort of thing that might come through education. But it's not something that the individual practitioner can readily get to grips with. What he probably wants is to be able to identify and prioritize the patient who's at greatest risk and in whom, for the cost of treatment, there is going to be the greatest response. And that's the kind of thing we're trying to do with the Derriford Weight Management Clinic, is to identify those at greatest risk so that we can get the greatest response for the moderate costs that are available to us. We look at these patients in a very systematic manner so that we are, over a period of time, able to collect the data from all of them, put it together in some kind of meaningful data set. And what we hope to be able to tell the Primary Care Trust, who is part funding this venture at the end of 3 years, is how effective is this process? How much does it cost? What kind of manpower involvement is there? And really, is it possible, is it viable to crane that out of a hospital into the community and clone it around the community with guidance from the hospital so that the community can benefit, because ultimately the hospital is not going to be the provider of such services for a large number of people. So I think I'll leave it there, Val. Thank you very much.
Okay. Well, thank you very much indeed, Terence, for putting this particular subject into context. And I think certainly making it very relevant to all of us. If it wasn't beforehand, I think it certainly is now. Now is your opportunity at the various sites to call in with your questions or comments in relation to what you've heard today already. The telephone number, just to remind you of that, is on the screen there, 01752 233 646, or of course you can email us. In the meantime, I'm going to ask a few questions of my colleagues on the panel, and I'm going to start off with a question to Gillian, if I may. Gillian, we've heard about the workshops from Morag a little earlier. One question that I'd particularly like to ask: why the workshops when we already have clear guidelines, particularly in relation to prescribing?
Yes, Val. I think NICE guidance has come with a lot of fanfare. It's often criticised, and in general it costs quite a lot because it's recommending the use of drugs which we haven't previously had available. In the Plymouth community, we take that responsibility very seriously, and we want to make the interventions that are recommended by NICE available to the appropriate groups. But we recognise that within the community we already have a lot of work going on. And this was an opportunity to bring together and to look across the health community with representatives from primary care, from industry, from many of the other groups which are associated with the obesity business, at how we can best implement these guidelines. When you look at the NICE guidance, Morag has reviewed the evidence base behind them, but the guidance itself is actually very much wider than that. And implicit in that are recommendations for the screening of patients, for the follow-up of patients, for their management within clinics. So as part of this workshop, what we wanted to do was to look at how we would implement a Plymouth obesity action plan, both for the community and the individual. And we particularly focused in the workshop groups on the screening and identification of patients, and then secondly, in the follow-up of patients in the community. We were able to identify some very good examples of good practice already occurring in the community, although we did find that we were disappointed at the amount of multidisciplinary team working that was going on, and that seemed to us something that we wanted to look at. But importantly, as an outcome of this, we hope that we will set up a group that will work together to make sure that we have an integrated program across primary and secondary care in the community, so that patients can be identified, offered treatment where appropriate, offered support and motivation, and then followed up so that we're able to actually control this issue.
Thanks for that. I have received an email that captures a little bit of what you've been saying, and it starts off by saying one of the unavoidable problems with these types of NICE technology appraisals is, of course, the lack of comparison between the different treatments. You're hoping through your workshops and you're following through that you will not only be able to identify the appropriate treatment for individuals, but indeed make comparisons.
Well, I hope so. What we're hoping to do, in accordance with the NICE guidance, is to set up proper audit programs, both of individual compliance and also of the way these are taken up. Certainly the feedback we had at the groups was that many patients find these drugs very difficult to tolerate, and a surprising amount of feedback about the dropout rates. So these are very important issues that we need to pick up.
Thanks. Another question that I had on the email, and this is from the Plymouth site, was presumably NICE does not give any information about relative costs. Is that the case?
No, it doesn't, and the cost effectiveness and the quality of life years that you get as a result of these treatments is part of other data which is available to us. I think from our perspective in these workshops, we have undertaken them with the understanding that we believe that these treatments were recommended by NICE should be available, but what we want to do is make sure that the treatments are targeted in the most appropriate way possible.
Okay, thank you. I have another email here that I'm going to direct to Professor Wilkin. It refers to the points that you were making, specifically in relation to the problem experienced amongst youngsters, and my email has given up on me. Here we go. You talk about different strategies, for example, public health, individual practitioners, those sorts of approaches. Does the panel have any comment on the relative benefits? Is there any evidence? And then how do you think that we should emphasise treatment rather than prevention?
I think there's an enormous amount of evidence.
It's a huge question.
It is indeed. It covers just about everything.
It certainly does.
But it's an important one, because intervention must have effect if it's going to be viable and pursued. The question of public health measures is obviously a very difficult one. How do you shift the behaviour of a whole population? We can only look at it one way round and say that, well, we do have health measures of 20 years ago, and we know how they've changed contemporaneously with the change in body weight. How to get it back again, or to turn this enormous ship round and get it going the other direction, is a huge problem, and my belief is that it will only come through education. We do things very differently in this country than we do indeed over the channel. The French approach to nutrition from a very young age in terms of educating their children is quite different than it is in the UK. The same is true of nutrition as it's given and taught at schools. It's a very serious matter. Primary schools have committees involving children as well as parents and teachers, which will determine the nutritional content of what the child's getting. It's given a huge priority. You know, there aren't sweet shops on the way to school in France as there are in this country. All sorts of cultural differences, and the French are a good deal slimmer than we are as a nation. But that's big, major shifts in culture, lifestyle and behavioural population, and very, very difficult to get moving, but we have to do it. I think much more germane to the fact that as practitioners we have individuals consulting us is to know how to manage this. And I think, I mean, my own belief that this starts with psychology in the adult and with education for the child. When I say psychology for the adult, I think anybody who runs a weight management clinic is well aware that there are two quite different groups of patient. There is patient A who says to the doctor, right, now I've got a weight problem, but it's your problem. I want you to tell me how I'm going to deal with it, and I'll go home and respond. There is group B who says, I've got a problem, I know it's my problem, I know I've got to do something about it myself, but I need your advice and your encouragement. Those two groups are black and white, and their response to weight management advice is black and white. And I think that's where it starts. I think it's with the psychology and the behavioural acceptance of where the problem lies.
Thank you. Rosie, did you want to come in there from the GP's perspective?
I think we're aware in general practice that some of us are guilty of prescribing outside of the guidelines, and I think this reflects consumerist pressure that the people who should be given the drug and the people who are asking for the drug are not the same. It is my impression that the public are well aware of these drugs, and if you're asked to give something, even when you are not so sure that it's going to be beneficial, it can be quite hard to say no to desperate people. I also think that we do have a large number of patients. I personally have a list of 2,000 patients, of whom 253 are eligible for this drug, and it is a very difficult matter to decide who to prescribe it to and who not. I could spend £126,000 tomorrow if I started all the eligible patients on this drug, so I think discussing where to use it most effectively is tremendously important. I also think that motivation is a very, very important thing for us to assess, and I certainly know in primary care that we would welcome some help and advice about how best to quickly assess people's motivation.
Okay, thank you for that. Terence focused a little bit, or quite a lot, on the education required, particularly in relation to parents of children. I wonder if I can pose to you, Christina, your clinic, your research obesity clinic, I think that's correct, deals with people between 18 and 35, the young and at risk. Do you, through your clinic, also try to educate those parents or potential parents in relation to the potential problems of their offspring, or is that picked up somewhere else?
Well, in general, what I'm trying to do in my clinic is educate the patient on their whole eating habits as a whole. So if they are about to become parents, they should have the skills then to cook for their family. They're going to hopefully, by the time, hopefully they'll stay with me for 3 years. So not only will they have weight loss, but they'll have developed skills of cooking, everything, shopping techniques, everything like that we try and go through. So we're not just always focusing on you must eat this. It's giving ideas, everything like that, so they will have the tools. So when they are parents, to teach their children that, and that will be their way of eating. So therefore it will come down to the way their children eat. Okay,
and is your clinic unique in that?
The main unique thing about my clinic is I have a machine called an indirect calorimeter, and that basically measures patients' resting energy expenditure. And from that we can get a precise figure of how many calories each patient needs in a day, and therefore then I can give them a prescriptive diet based on how many as an individual, how many calories they need in a day. So it's quite specific towards each patient, and every patient is different, as we all know.
They certainly are, yes.
That is the most unique thing about our clinic, and we have lots of different treatment strategies using Orlistat, Sibutramine. Surgery is included as well if we feel someone is appropriate for surgery, we refer them to the consultant surgeon in Derriford.
Right, thank you. Can I ask the panel if there have been any particular surprises that have come out of the workshops?
Let me kick in very quickly. I don't think it was a surprise, but it was an awareness, and that is that the logistics of managing patients in the community is so different than they are in hospital. And I think you were talking earlier about the multi-professional approach and how important it is to have viewpoints from a number of different, not just professional inputs, but also circumstances in which you're trying to deliver a service. I think we are highly protected in hospital with patients who are already selected by their general practitioners, and they come up to a hospital. It's a relatively secure environment in which to get advice and so forth, and there is time, often more time than there might be in primary care. I think that's a very, very difficult thing, and yet for primary care, I mean, that's where the coalface is, and that's where these patients will first get the advice they need. And I think it's a very difficult logistical problem for the general practitioner.
Thank you. Any other surprises?
I think for me the difficulty was picking up a model that we could translate into other populations. It was very interesting talking to the people delivering the care in the community, how many different strategies, different practices had implemented. We had nurse-led clinics, community dietitians, GPs, and how little cross-modality, cross-professional working there was in coming together. For example, we heard how nurses were very effective at running clinics. Community dietitians were coming in, had very good response rates, very, very high dropout rates, but didn't run the clinics with a nurse, so that they couldn't make the measures of comorbidity that Terence was identifying as being so important. So for me, the big take-home message was that we need to start working together, and with relatively little effort, because we're already putting the input in. It's going into lots of places in the community. We need to find a way to bring it into one coherent way so that we can deliver an effective service.
Identified working together there. Tell me who's participating in your workshops.
Well, the group we invited to the workshops were people, doctors, nurses, hospital practitioners associated with looking at guidelines and evidence-based practice. We invited members of all the community, general practitioners, practice nurses. We also invited industry, people who make the drugs and try and sell the drugs, and we invited a much wider range of representatives from the weight loss clinics, the Rosemary Conley, a much wider area, representatives from fitness clubs, personal trainers. So we're really wanting to bring in a very wide group of people within the community who we think can implement and act on this problem.
And where do we go from here?
Well, we'd like to set up a group which we believe was started at the workshop on Tuesday, that will take these guidelines, look at the model of the clinic which we're running in the hospital at the moment, take not obviously the research elements of that, but take some of the much easier elements, the fact that perhaps instead of scales we should have a tape measure, as issues, and look at ways that we can change that into individual obesity action plans, targeting those people in the community who we know are at risk of the comorbidities, so that we can make sure that the investment that we're making in these drugs has the maximum impact on the disease profile within the population.
And Rosie, from the GP's perspective, will these workshops help you in your decision making?
I think we already do a lot of work, and we've been trying to help patients lose weight for a long time. I think what we need to focus on now is making sure that we're doing that effectively. So I think the guidelines have provided a sort of wake-up call for primary care to make sure that we are thinking that where we are working, who we are prescribing to, we are making the right decisions to be most effective at delivering it to the correct people, rather than being led somewhat by the nose by patient demand. but that is a difficult culture change. Also, we have so much disease to deal with. We have so many people who are ill here and now with their obesity that although intellectually it's tremendously attractive to change our focus to treating further down the line to prevent disease, trying to find the time to do that when we're firefighting in the front line is quite a challenge.
I'm sure it is. I'm sure there's a range of challenges ahead, but I certainly believe that if you've got a collaborative group, as you have for this particular approach, that can only augur well for your patients. That's great. Well, I'm at the point now where I'm going to draw today's seminar to an end. I thank you very much indeed for participating. If there are any inquiries that you'd like to ask of the panel, please do email. They can be handed on to us and responded to at a quieter time when you've had more opportunity to reflect on today's broadcast. I look forward to seeing you in December, which is the next seminar for the NICE group. The seminar is happening on the 5th of December, I'm just referring to my notes here, again between 12 and 1, and on that occasion the focus is going to be around wound care, pressure aiding devices and leg ulcer management. I hope you'll find time to join us there. Safe journey home this evening, and thank you for joining us. Bye-bye.
Trials and systematic reviews and meta-analysis of these randomized controlled trials. This is usually assigned a number 1. In the levels of evidence, 1 can be a 1 plus or a 1 minus depending on the quality of the studies involved. But the key point for us to note is something that's given a 1 level of evidence is gold standard and has statistical power when we talk about the effectiveness of interventions, which is really what we're discussing today. As we come down the hierarchy, we have systematic reviews of case control and cohort studies where we have less statistical power, but we can still be reasonably confident about the effectiveness of the intervention. Non-analytic studies, which include qualitative research studies which tell us about the patient's perspective, another very important aspect of interventions. And at the bottom of this particular hierarchy is expert opinion. But in some cases, the best available evidence is expert opinion. As well as this hierarchy of levels of evidence, with systematic reviews given a 1 and expert opinion given a 5, evidence is graded in terms of A, B, C and D. A level evidence or grade of evidence again is considered high quality. So as I go through the technology appraisals today, if I assign something a level 1 plus or minus and a grade A, it would be taken to be high quality evidence. The first drug that I'd like to consider is a drug called Orlistat. The technology guidance was issued in March 2001, and with all of the technology appraisals, this will be reviewed 3 years later. The pattern for reviewing the technology appraisals will be looking at the mode of action, how the drug works, and what side effects the patients might experience. This particular
Good afternoon, and welcome to the first in a new series of satellite seminars which focus on the implementation of National Institute for Clinical Excellence, NICE, guidelines. Plymouth Primary Care Trust, Plymouth Hospitals Trust and the Institute of Health Studies have collaborated to form a Plymouth Health Community NICE Guidelines Implementation Group. The group aims to offer bi-monthly workshops and a satellite seminar on selected NICE guidelines. Today is the first of these satellite seminars and is entitled NICE Guidance Implementation for Orlistat, Sibutramine and Surgery for Morbid Obesity. To commence, Dr. Morag Prowse, Head of the Department of Clinical Studies in Adult Nursing, offers an overview and critique of the evidence for the 3 NICE guidelines relating to treatment for obesity. Then, Professor Terence Wilkin, an expert in this field, provides an overview of the impact of obesity on the health of the population, locally and nationally, and in addition reviews current practice in the medical management of obesity. Our panel will then discuss factors which influence the implementation of this NICE guidance in the local health community. As usual, you're invited to participate in our seminar through studio discussion. You may either telephone.
Killer drug works by very effectively reducing fat absorption from the gastrointestinal tract. Because of the way it works, patients might experience a reduced absorption of fat-soluble vitamins, which can create dietary problems. But the patients can experience a range of quite distressing gastrointestinal side effects related to increased bowel movement, frequency of bowel movement, and anal leakage or anal soiling. An important point to note here is that if the patients are in the experimental part of the research, they're likely to be aware that they're having gastrointestinal side effects, as are the researchers who are carrying out the study. Orlistat's indicated for use with a BMI or body mass index of 28 with comorbidities. And in terms of body mass index, someone of my height, 5'4", if my BMI was 30, I would actually weigh 80 kilograms, or for those of us like me that haven't quite converted to metric, I would be about 13 stone. The drug is indicated for use only between patients between the ages of 18 and 75. And for this particular drug, the recommendation is the patient should have demonstrated motivation by a weight loss of 2.5 kilogram in the months before treatment commences. And this is a very key aspect because managing weight is a long-term problem, and it could be argued drugs provide short-term solutions. Use is indicated when there is concurrent advice, support. This can include diet, behavioural change, increase in physical activity. Patients continue on the drug if they've lost 5% of body weight after 3 months, and if they go on to lose a further 10% after 6 months. But the drug is not indicated for use beyond a year. When we consider now the effectiveness, patients do lose weight on these drugs, and they lose weight at a faster rate than patients in the control group over a year. They have a reduction in comorbidities, and not surprisingly, the patients tend to feel better. They have an increased patient well-being because they have, in fact, managed to lose weight. In general, patients do regain weight after drug therapy or after dietary changes, but looking at the trials, the weight was regained at a slower rate than the rate it was lost during therapy. When we come now to look at the quality of the evidence is based on systematic review of 14 RCTs, randomized controlled trials, with some risk of bias, but the risk of bias is almost inevitable in studies carried out outside of laboratory settings. On that basis, I think this evidence would be rated as a 1+ and a grade A, because the quality of the RCTs was generally high. Some issues and gaps in the evidence are worth considering, and in terms of judging quality of evidence, there are 2 things that researchers tend to look at. Is the study internally valid? Has it high internal validity? And does it have external validity? Things that can affect internal validity come in 2 categories. They can be either biases, which tend to be things to do with aspects of method, or they can be confounders, something that could influence the treatment effect. And those are important aspects to consider as we make judgments about the quality of evidence. External validity of a study refers to the ability to generalize from the particular study to a wider population. In general terms, where randomization has taken place, the external validity of the study can be reasonably assured. For this particular technology appraisal, there were issues really here because there wasn't a...
Or email us with your questions and comments. The telephone number is on your screen there, 01752 233 646, and the email address is tvstudio@plymouth.ac.uk. We will be ready to receive your calls at approximately 25 to 1. Today's panel consists of Dr. Rosie Heath, a local GP, Professor Terence Wilkin, a specialist in endocrinology and obesity management, Dr. Gillian Vivian, consultant in nuclear medicine, who chaired this week's workshop, and Christina O'Riordan, a senior dietitian from Plymouth Hospitals Trust. Welcome to you all, and thank you for your participation. Now, without further ado, I hand over to Morag.
Good afternoon, and can I echo Val's welcome to the first of the NICE Guidance Implementation Seminars. My role today is to briefly review the technology appraisals for the two drugs, Orlistat and Sibutramine, and the surgery for morbid obesity. But my particular focus is to consider the evidence underpinning this particular NICE guidance and make some judgments about the quality of that evidence. In evidence-based healthcare and evidence-based medicine, the effectiveness of interventions such as drugs or surgery is judged against an established hierarchy of levels of evidence, and it would be useful before we start reviewing the technology appraisals just to recap these levels of evidence. This is derived from the well-established work by Sackett and colleagues from the Canadian Task Force in '96. These levels of evidence form a hierarchy. At the pinnacle of the hierarchy is experimental methods, but in particular randomized control